Hi, everyone. My name is Brenton Bauer, Dr. Brent Bauer at Core Cardiology here in the Los Angeles South Bay, bringing you the next in the series of the California American College of Cardiology Cardio-Oncology webinar series. We have a co-moderator, today, Dr. Nikhil Bassi, who's at Hoag Hospital down in Newport Beach. And we have two amazing presenters that we're very honored to have with us from Cedars-Sinai Medical Center, both renowned in their fields. Dr. Caitlin Atkins, who's an assistant professor of radiation oncology and an associate residency program director for the Department of Radiation Oncology at Cedars-Sinai. And also we have Dr. Andriana Nikolova, who's an assistant professor in the Advanced Heart Failure and Transplant Cardiomyopathy Department at Cedars-Sinai Medical Center. Again, really proud and honored to have all of you here, both from Cedars as well as Nikhil from Hoag, and we look forward to discussing today this very interesting and important issue in cardio-oncology, which is really radiation oncology and cardiovascular toxicity. So let's take it away.
Great, thank you so much, Brenton, for this invitation. We are so honored to be here and to present our topic on lung cancer therapies and cardiac toxicity. So we have a lot of ground to cover today. I'm going to start with overview of lung cancer incidence, mortality, and the treatment landscape from my cardiologist point of view. And then we're going to delve into a little bit case-based discussions on thoracic radiation, particularly, and various cardiovascular toxicities. And if we have time, we'll cover a third case on targeted therapies and cardiovascular risk. So I call lung cancer kind of the orphan or neglected child of cancer because we really see it completely underrepresented in our cardio-oncology clinics, despite these patients being at extremely high cardiovascular risk, as we're going to demonstrate today. Probably this is due to the fact that lung cancer is still the leading cause of cancer-associated mortality, and probably the perception is, well, these patients are doomed. Why care about their cardiovascular risk? And today we want to show you that really with the advances in the field, this is completely changing. These patients are living actually very productive and meaningful and long lives. And so we want to really pay attention to their cardiovascular risk optimization. On the right-hand side, you can see in red the lung cancer-associated deaths compared to other cancer-related mortality. And you can see that over the last couple of decades, really that is sharply decreasing. Probably there's a couple of factors in that. One is in 2013, the United States Preventive Task Force introduced the lung cancer screening guidelines. So we're detecting these cancers at earlier and treatable stages. And in addition to that, the treatment advances in the field are pretty remarkable. These patients now have the options of targeted therapies that are directed against specific disease-driving mutations, as well as immune checkpoint inhibitors are transforming this cancer landscape as well, just like in many other cancers. And in addition to that, the CDC is really driving campaigns to decrease the smoking rates in our country, and still 80% of lung cancer deaths are related to smoking. So me as a cardiologist, this is the framework I think about when I think about lung cancer treatment. So if a patient is early stage, he's going to receive surgery and radiation therapy. As he's developing more locally advanced or metastatic cancer, this is where we come into play some of the chemotherapies, the immunotherapies, and the targeted therapies, in addition to palliative or curative radiation therapy. So as a cardiologist, in terms of chemotherapy in lung cancer, the important thing to know is that really the backbone of chemotherapy is still the platinum doublet. So cisplatin or carboplatin are one of the agents used in the chemotherapy of these patients. Immediately, I think of associated increased endothelial oxidative stress and associated vascular effects. So I'm thinking about increased risk of MIs, of strokes, of long-term hypertension, and particularly with cisplatin, because of nephrotoxicity, there's a lot of electrolyte shifts and associated cardiac excitability, such as SVTs, atrial fibrillation that we see a lot in our practice. The antimetabolite pemetrexed is less cardiotoxic, so I'm not worried about it as much. And the microtubule agents such as taxanes paclitaxel, docetaxel. They're associated with infusion-related bradycardias and heart blocks, usually transient and reversible, so I'm not worried about them. The next main big category of treatments are the immune checkpoint inhibitors, the new kid on the block that's transforming the lung cancer field. And the main thing that they worry about them is this accelerated atherosclerosis that's been shown both in animal models as well as in cohort studies following people with imaging and showing they develop plaque at a greater rate when treated with immune checkpoint inhibitors and at about threefold higher risk for cardiovascular events. Of course, the myocarditis is the feared but rare complication. And the audience can refer to the latest webinar that kind of covered in depth this topic. So we still don't know how the ICIs are going to interact with other therapies, the radiation therapy, and how we should really protect and optimize these patients because they're used both in early stage lung cancer, in locally advanced lung cancer, and in the metastatic setting. And look at this, even for metastatic lung cancer, 5-year survival is about 30%. Sometimes this is a better prognosis than our heart failure patients, in which we throw so many resources for cardiovascular management, and we're neglecting the lung cancer population. So we're hoping to bring awareness to this patient population. Of course, the targeted therapies are extremely important, and they're directed at various disease-causing mutations. The biggest one that I see in my practice are therapies directed against the epidermal growth factor receptor, associated heart failure, or just asymptomatic EF decline, usually reversible. And we're going to see a case today related to that toxicity. But with all of these tyrosine kinase inhibitors, we do see quite a bit of cardiovascular events as well. The biggest kind of fear for me and the biggest treatment modality that I fear for my patients is thoracic radiation. And this is really the central topic of this webinar. So radiation therapy is going to be the treatment modality for about 50% of the lung cancer patients. And we know from the breast cancer literature that each grade of mean heart dose leads to 4 to 16% relative risk increase of heart disease and major cardiac events. I mean, this is pretty remarkable. And we know the kind of the manifestations of cardiac toxicity associated with radiation. Coronary disease is the big one. It causes kind of very remarkable osteostenosis, valvular heart disease. The radiation beam kind of traverses the aortic and mitral valves and causes AI or mitral stenosis or regurgitation. In the pericardial space, we see a lot of pericarditis, pericardial effusions, much more rarely constrictive pericarditis. We see a lot of cardiomyopathy, particularly HFpEF, much more rarely kind of the restrictive heart disease as well in our heart failure clinics. And conduction system disease are very important as well, right bundle branch block or frank complete heart blocks and need for pacemakers. Of course, all of these therapies, in particular thoracic radiation, interacts with the patient's underlying cardiovascular risk burden. The more cardiovascular risk factors the patient carries, the less his cardiac reserve is and the greater risk of toxicity. And really, how did we screen these patients? The kind of general consensus was this is a delayed toxicity, start screening at about 5 years and start screening patients that receive 30 grays of radiation or more. And we'll see by today's talk and Dr. Atkins' groundbreaking research that the time course of cardiovascular toxicity is much more accelerated on a shorter scale, and we need to really screen and consider at much earlier stages. So these patients in general are at some of the highest cardiovascular risk, and probably because there's the shared risk factors between cardiovascular disease and lung cancer. 80%, as I mentioned, of lung cancer patients were smokers recently or at some point in their lifetime. They're at kind of more advanced age. They have a lot of systemic inflammatory risk factors. And overall, these patients have 66% increased risk on cerebrovascular disease and 90% increased risk of coronary disease. So today we're going to delve into various cases to illustrate this much more accelerated and aggressive course of thoracic radiation and heart disease. And I'll start with the first case. So this is the case of a 59-year-old male with a history of hyperlipidemia and remote smoking history. He presented with 1-month history of left shoulder and neck pain and dyspnea on exertion. He was diagnosed on CT angiogram with right-sided PE, as well as very bulky left hilar mass and left upper lobe mass. Ultimately, he was diagnosed with metastatic adenocarcinoma. He had about 30% PD-L1 expression. So after surgery, he was started on immunochemotherapy with Keytruda and carboplatin and pemetrexed. After the initial induction, he was maintained on pemetrexed and Keytruda. Ultimately, he had progression of intrathoracic disease and was started on radiation therapy to the left hilar region with planned 30 gray delivered over 10 fractions and continued on the immunochemotherapy. So this is his radiation planning CT, and Dr. Atkins is later gonna kind of walk us through the biggest considerations in the planning of these therapies. But you can see that the radiation beam is blasting right through important left-sided cardiac structures that make me cringe as a cardiologist. And when I see 30 grays to the left hilar region, I already am prepared that this is gonna be associated with much more significant cardiovascular toxicity than other patients. And so it wasn't a surprise when 2 years post-diagnosis, the patient presented with chest pain that was pressure-like, he was diaphoretic and short of breath, he had troponin elevation, and EKG demonstrated ST elevations in the septal leads with Q waves and diffuse ST depressions. So we were very concerned about left main disease versus 3-vessel coronary disease, and he was emergently taken to the cath lab. And lo and behold, he had the typical radiation-associated osteo left main disease, these very fibrotic plaques, tubular and circular and concentric in configuration that are typical of radiation-associated heart disease. And the patient had a hard time. He underwent impello-assisted left main PCI, complicated by hemopericardium. He needed to have pericardial drainage, and it was a big kind of task managing the bleeding risk in him with the prior history of DVT and P that he had sustained. So huge ordeal for this patient, and luckily he made it. But could we have foreseen this as cardiologists and as just the general community looking at these patients? So for the traditional cardiovascular risk assessment, the patient had the risk factors of smoking and hyperlipidemia. This is his lipid panel right before initiating therapy with an LDL as high as 180, and he was not on statin. He had no hypertension, family history of coronary disease, diabetes, or obesity. But these traditional risk factor assessments don't factor the fact that he was on prolonged immune checkpoint inhibitor therapy and that he received really high dose radiation therapy to the left-sided regions and transversing right across the cardiac structures. So for the pooled cohort equation, his 10-year risk of ASCVD is about 6.9%, which is not very high. And basically, we know that in cancer patients, these traditional cardiovascular risk scores really underestimate risk. For example, in a cohort of breast cancer patients who are considered at low cardiovascular disease risk for the Framingham risk score, they had much greater rates of cardiovascular disease compared to their cancer-free counterparts. And similarly, in another cohort of breast cancer patients, in whom CTs demonstrated the coronary artery calcium scores greater than 100, 1/3 of these patients did not have any traditional cardiovascular risk factors. So we do use coronary calcium score to further define and refine the risk in these patients. This patient did not have any coronary calcifications on the radiation planning CTs. And for the ACC guidelines, probably would have been very kind of in between whether to start a statin or not if this was just a regular patient not receiving all of these aggressive cancer therapies. But what do the guidelines also recommend about cardiovascular monitoring in this patient after he received the radiation and all the other chemoimmunotherapy? And the consensus guidelines are sparse and the data is still evolving. And Dr. Atkins is going to educate us on the latest and greatest in the field. But the general consensus, as I mentioned, was, well, these are delayed effects. Start worrying 3 to 5 years after the radiotherapy and start screening these patients at that point. But is that truly so? And Dr. Atkins is going to show us now that really these are big myths that we need to kind of reconsider in view of the new literature data. So I'm going to turn it over to her.
Thank you, Dr. Nikolova. So next slide. So to kind of start with just a little bit, we're going to go through just a quick, but a little bit of the nitty gritty of radiation. What does it mean? What is a prescription dose? Where are we targeting? What are we usually doing? What is the standard, and how can we do better? And what does this mean for how how radiation interacts with baseline cardiovascular risk, and the excess risk from toxicities of treatment? So when we think about how we give radiation in our modern treatment era, it can be anywhere from ablative stereotactic radiation, you can think of as small volume, high dose, ablating a small area. It can be large treatment areas and a combined chemoradiation therapy for locally advanced disease. And even in the metastatic setting, there's a growing role for consolidative local therapies in oligoprogressive or oligometastatic disease states where people have a good response, and you actually hit all local sites with a combination of local treatments, whether it be ablative radiation, surgery, or other local ablative procedures. And so there's a lot of therapies being combined. Oh yeah, go ahead, next slide. And so let's jump back to this radiation plan, which I think a lot of you might be alarmed to see, because one, we can deliver radiation in many ways. This is actually a standard of care, classic way to deliver palliative, what we consider low dose radiation in a very quick and emergent way. This can be for people who have spinal cord compression. In this case, it was compressive in the hilar area. It's a patient with metastatic disease. We often do traditional simple planning techniques. Simple meaning there's a beam from the front, there's a beam from the back, it's modulated very little. And you can see the yellow is like the 100% dose line of our prescription going through and through. What it doesn't show you is that this is only a short segment. So we're not blasting the whole heart. If you were to take traditional measurements of like an average heart dose, it's probably about, a hand 3 or 4 gray, I think, on this plan. But you can see where the segment is going right where we don't want it, which is right through the left main to the LAD. But this isn't appreciated well in our field, because what we think traditionally is often this is a very high cancer risk mortality patient who needs a short palliative treatment, and who from traditional data from like breast and lymphoma and cardiac toxicity would say there's a long latency to these events. So historically, this is an underappreciated cardiovascular risk situation that most radiation oncologists and oncologists don't put in a high cardiovascular risk category. But here we're in our data over the last few years, which I'll kind of go through. This means something I think very different now. And so here you guys could obviously appreciate that's a bad area to put a lot of radiation dose. I don't have to sell you guys this argument. And obviously this event happened only 21 months later, and this is not an anomaly. So next slide. So I often think about setting up these ideas about what have been like the myths in our field as oncologists and in radiation oncologists. Well, initially we had these built-in assumptions. One was that because for lung cancer, this high competing risk of lung cancer death, these traditionally low 5-year survival rates, that cardiac toxicity is just less meaningful in these patients. They're not going to live to experience it. And then we have this assumption that there's this prolonged latency. And while that was true with initial data from breast and lymphoma data series, where they're getting lower doses to the heart and they're lower baseline cardiovascular risk, and it might take 5 to 10 or 15 years to develop cardiac events, this is not the case with high dose thoracic radiation in high cardiovascular risk patients. And then also what we as radiation oncologists have done is traditionally put the very important risk of the lungs over that of the heart, meaning the dose has to go somewhere. And you can shape and spare and do all these creative and fancy ways we deliver radiation, but it still has to go somewhere. And we've often prioritized fatal pneumonitis risk over the heart traditionally, but we need to do things in balance more. And so what we've shown in some of our recent data and in conjunction with some of the recent data like Dr. Nikolova went over with things like longer survival with immunotherapy, the Pacific trial, even in the metastatic setting, is that 5-year survival rates are getting better. So patients are living longer, they're living longer to experience more. And that one is that cardiac events are common. So there's 2 initial studies that were published in JCO in 2017. They're small series, only about 100 patients from Michigan and North Carolina, that were the first to show in prospective lung cancer studies that these events are happening. They're happening about 10 to 20% of patients, and they're happening soon. And this started people thinking about what's really going on. And this is when we jumped in with looking at the largest series in the Harvard data set, with going through we wanted to detail who are these patients? What is their cardiovascular risk before treatment? Let's measure dose everywhere in the heart, and let's figure out who's getting what type of cardiac events. And we found that just, heart dose in general, we'll get through the where of this, is an independent predictor of mortality and MACE, even when adjusting for their high competing risk of lung cancer death. Next slide. And so just a couple slides on what radiation kind of means in the background to help you visualize what this means. And so current radiation planning uses a lot of sophisticated planning techniques now. We deliver radiation continuously on arc therapy with radiation beams being modulated to control the dose at every angle. So we can very much carve radiation dose off where we want when we plan ahead. And so we often, while we can't in the chest, often avoid the heart completely when we're treating lung cancer, there are trade-offs, and not one radiation plan may look very different from another, and just getting radiation can mean very different based on how it's planned and the experience and expertise of who's planning it. And importantly, we have to balance risk. We don't want dose in the heart. Well, we also don't want it too much in the lungs or in the spinal cord or in the esophagus. And we start having to weigh risks and balances between these. So we need to keep things in balance. And we also have to make sure that we get a high enough dose to the tumor for tumor control. Next slide. And so here's just a quick example of like what this can visually mean. So plan A on the left versus plan B on the right, where the high dose to the tumor is in the red. And you can see just by picking the arrangement of where the beams might enter more maximally, and here's like a static treatment rather than a continuous arc treatment. And we often measure things on a histogram, dose volume histogram, as we call it. So you can look at the graph and see that plan A has less area under the curve for the heart than plan B. So for this patient, we've carved off the dose more for the heart in plan A than plan B. This might mean everything else is the same, or sometimes it can come at a cost function to another organ, but not always. Sometimes it just means we need to set our limits more stringently. And so this just illustrates that there's a lot of variability in how you approach planning. But next slide. And this isn't meant to go through all of these, but this was like the state of the field as we began our work, which is that there were a lot of small series in lung cancer patients of cardiac toxicity. But to summarize this entire slide of what existed in the literature leading into the last few years was that most people were using non-validated or standardized cardiac endpoints. So things like defining their own symptomatic cardiac event or serious cardiac event, or grade 3 or greater CTCE, like NCI toxicity gradings, which can mean anything from arrhythmias or pericardial, but not necessarily separating out different types of ischemic events. Or it just might not be that detailed, or they're just using survival, but measuring cardiac dose. And most uniformly don't capture baseline cardiovascular risk. So most oncologic studies and most retrospective oncology studies are, when they're looking at initial studies looking at cardiac outcomes, actually do a very poor job of getting granular details on the baseline cardiovascular risk of these patients. So this left a lot of gaps in our understanding as we started. And so how we devised as we were going, kind of the principles of what we believed we should understand is that that in order to understand this, we needed to be able to evaluate radiation dose to not just. And when we say mean heart dose, literally what this is defined as the heart as the pericardial sac, from the inferior to the branching of the left pulmonary artery through the whole pericardium. We average the dose. So that is the mean heart dose. And you can imagine, as what you saw, dumping that through the LAD or the left main is very different than somewhere else. And where the dose goes matters. The gradients of the dose making an average can be very different from a breast cancer treating the upper just tangent area, or a lung cancer going through and through. And so we need to know where the dose is going. And then we need to understand how that interacts with people's pre-existing cardiovascular risk and comorbidities. And then there should be a logical pathophysiological pathway for this that actually measures an outcome that isn't a dirty endpoint like all-cause mortality. Because then when lung cancer patients, a lot of things are contributing to mortality. So we really need to see the in-between, which is that cardiac endpoint. And so our approach was to create a large data set. So we started with about 750 patients. We did detailed dosimetric data. Where is the radiation dose going? We individually kind of segmented and contoured the cardiac structures on the CT planning scans for all these patients, extracted their baseline cardiovascular health, and did and tried our best to adjudicate all of these cardiac events using kind of strict MACE criteria, as well as all the landscape of CTCE criteria that cover arrhythmias and pericardial and et cetera. And so what we found expectedly is that these are high-risk patients. It's a high-risk cohort, as Dr. Nikolova already, highlighted. They have a high Framingham risk. They have a lot of history of hypertension, hyperlipidemia, diabetes, or known CAD or CHD. But when we first started looking at this data, we found that yes, they're having these the MACE events, and they're having them early. And so the median onset of these is about 18 months. And if we just look strictly at their baseline cardiovascular risk, patients who have known coronary heart disease, they really do, at 2 years, having a 12% rate of MACE events just by having known high risk and these high cardiovascular treatment, but high cardiovascular baseline risk was a pretty significant number. And you can see in the breakdown, they're getting a lot of other types of events. And actually our next case will kind of illustrate and come back to arrhythmia. But what we wanted to first focus on is the high morbidity events, the ischemic events and cardiac death and strict MACE events. And so what we found in our first analysis, just looking first at the whole heart dose, because that's the standard in our field, with the mean heart dose, is that it associates with both MACE and mortality. And so this case with a hazard ratio of 1.05 per gray. So similar to breast cancer, where we see about a 5% risk per gray with no clear threshold of this. And that when we stratify by a mean heart dose of greater or less than 10 gray, we can see dramatic differences in even 2-year MACE rates of 4% versus 1% and a 12% difference in mortality. And this is just at the 2-year mark. Next slide. And so what we found from this actually is that not only is heart dose in general associated with MACE and mortality, which have not been clearly demonstrated in lung cancer to be associated with strict cardiac events like this, is that actually the lower cardiac risk patients at baseline, you can tease apart this relationship more visibly. Like the patients who are lower cardiovascular risk, you can see a dose relationship much easier. And we hypothesize that doesn't mean because we don't see that relationship in the high risk patients, it's because largely we've exceeded the threshold for high risk patients. They're having events at high rates. So even smaller amounts of radiation tip them much easier. So it's harder to tease out a dose response when they're all getting exposed to high dose and having a high event rate. So I think it even warrants that we need to be extremely mindful of the high cardiac risk patients as they come into it. And this is just a visual. I think it's helpful to remember that when we talk about everyone thinks breast when we think about radiation toxicity, and everyone gets in this controversy about modern techniques and, heart dose really matters. But to really put it on a scale for you, lung cancer limits for the heart really went from no constraints to a mean of under 35 gray in the mid-teen 2000s. And then was at 26 gray, actually, when I was in residency training. And then it wasn't until we were doing this work and those 2 JCO papers came out, and as we were putting out our work, that the actual national limits went on the NCCN guidelines down to a recommendation of under mean gray, a mean of 20 gray. And to put it in perspective, most breast non-regional node radiation plans have a goal of mean under 1 to 2 gray and up to 3 to 4 for regional nodes included. Just to give you a scale of the type of magnitude of radiation exposure that's different between these types of treatments. And I don't minimize breast either, because we could do a whole other on breast toxicity. But also, I usually like to illustrate that while we think so much about mean heart dose, it might actually not be that great to use. As you can visualize all the different ways you can get an average to a large structure. This is where the dose goes really matters, because if we're going to tease this apart, we need to do better than an average dose to the whole heart. Next slide. And so this is where we basically took the same analysis and went through where is the dose going. So we just basically contoured out all of the chambers and the coronary arteries to start with. So next slide. And so really what we found is we just did the same analysis, but we did a sensitivity analysis for basically every structure and every dose parameter from mean maximum to what we call increments of volumetric dose exposure, like a volume getting of the volume in percent or CC getting 5 gray, 10 gray, 15, they're all the way up to 60, 70 gray. We did a sensitivity analysis on all of this and found that the LAD actually has the highest association and on a sensitivity analysis for predicting MACE events, which pathophysiologically makes sense. And we found that it wasn't a high dose. It's not like the max dose. It's like a low to moderate dose. A low to moderate dose to a critical volume of the LAD is the most predictive for MACE events in these patients. And what we found that particularly in the lower cardiovascular risk patients, even stratifying by a moderate LAD dose of what we call greater or less than 10% of B15 gray, which doesn't matter, but we went from having 5% or 0% on the cut point just by that. And if you go to the next slide, and that's even at 1-year MACE rates. And we found that it was associated with both MACE and mortality in the same way that mean heart dose was, but it was a much stronger predictor of MACE. But this is why it's important, is that if mean heart dose was a surrogate for LAD dose, then great, we could just use that. But it all depends on how concordant it is. And we've shown this, and other breast cancer data has shown this, that measuring the dose to the LAD and measuring the dose to the whole heart, they're discordant in much of the time. And so we actually found that if you separate this out, you can have a high mean heart dose and a low LAD dose, or a low mean heart dose and a high LAD dose. And really it's the LAD dose that drives it. If your LAD dose is high and your mean heart dose is low, that's going to account for your risk much more than a high mean heart dose that avoids the LAD. Which to you guys, I think makes sense, but it takes a lot more convincing to our group, maybe. So we've shown this several ways. We showed it in this cohort. We validated it in a CEDARS cohort and a prospective randomized clinical trial, this RTOG data set of randomizing to high dose radiation or not. We validated this LAD metric, and we've also in some unpublished work validated in breast as well. So it's really just going to show that you can do better than measuring the whole heart, and we're hoping to have this metric now be incorporated on one of the upcoming Alliance lung trials is going to incorporate this, and we're hoping that this gets into more consensus guidelines for treatment planning in the upcoming couple of years. Next slide. And so what we say is, well, can we avoid this risk? Is it hopeless? Are we just destined to always have to blast to the heart? No, and I think we can think about this more simply than we traditionally have. And so that's that it might be easier than we think. So one is that cardiac dose can be a modifiable risk factor. It's not that we can avoid it entirely, but we can be thoughtful in the ways that we plan and avoid where we can. Also, as you guys well know, many of these patients may not even get to you, but are not medically optimized. So that's a modifiable risk factor at the start, just them seeing a cardiologist and have someone just optimize and care about these baseline cardiovascular risk and improve our screening of high-risk patients. What opportunistic data do we have to utilize, like CAC measurements on diagnostic oncology scans to look at this? And so here's just a little bit of data we did on just statin use and optimization. So one, as you guys would expect, they're poorly optimized. So even very high risk patients who have known coronary disease or high Framingham risk, statin use is only about 50%. And this is consistent with epidemiological data looking at this. Really about half of your highest risk patients are usually on a statin. And so there's a significant gap. And we actually found that when we looked at this cohort that there was an increased association of increasing mean heart dose with mortality in statin naive patients, but not in those already on statin therapy, which for us suggested that there might be a possibility that that an intervention with statins might be able to mitigate some of the effects of high radiation dose in these patients. And the other opportunity we have is before patients even get to you guys, we're getting a lot of information that we can utilize. So, things like everyone's getting CT scans for their cancer at the beginning, the radiation planning staging, even just looking if there's gross coronary artery calcification and triggering, while they have hypertension, hyperlipidemia, someone should be seeing this patient and seeing if they're optimized. I think it's a very kind of low-hanging piece of fruit that we don't do a good job of. And we've shown this, at least in lung cancer cohorts, where we've done deep learning automated CAC measurement in these patients, and actually these can identify patients where just the presence of that or absence of that associates with mortality and MACE events, even in a cohort that has a high lung cancer death rate. All right, so I'll switch to Dr. Nikolova to introduce the next case, or we can pause here, or before we get into arrhythmias, maybe you want to pause here.
Yeah, maybe we can pause for a minute and see if the audience has any questions. And I think that was an excellent first presentation. You know, number one, it reinforces that the Framingham score is really not sufficient in risk stratification. And in this case, although the Framingham score was low, clearly the LDL of 184 was a major risk factor. But I also think it challenges some of what we thought we knew. And Dr. Atkins, you did, I think, an excellent job of explaining that, you know, number one, it's not just late effects, it can be much earlier. And number two, that the mean dose, the heart, dose is not really the right way to be thinking about the effect that this has on the heart. So I thought that was really an outstanding presentation. Maybe a couple of questions for each of you. So for Dr. Nikolova, do you think that that there would be a role to do screening sooner, and you guys kind of maybe hinted at that, but like for, with this patient, for example, assuming that we did start to see some coronary artery calcification, develop, would there be a role to do a stress test or a role to, maybe do a CT coronary angiogram, even if the patient isn't necessarily having any symptoms yet? And then Dr. Atkins, I guess a question for you, which is, as a cardiologist who treats these patients, if we're worried about the patient and we think that maybe they have risk factors, what's the best way to sort of, have that conversation with the radiation oncologist? What are some tips or suggestions you might have for us?
Yeah, Nikhil, thank you so much for this great question, because I'm really a big believer that based on this data from Dr. Atkins, and she completely changed my kind of view of how I approach patients with lung cancer that are going to undergo radiation therapy, is we really got to screen these patients much earlier, because the mean time to an event is about 15 to 18 months. It's not that delayed a manifestation of toxicity of 5 years. And if you think about it, I mean, many of our patients that come to our cardiology clinic, just by the fact that they have a smoking history, I'm so aggressive about screening them for coronary disease, doing either CAG scans or just CT coronary angiograms. And in the smokers especially, I see such a prevalence of a coronary disease without any other risk factors besides smoking. This patient who has a smoking history and hyperlipidemia, I'm going at baseline to definitely look at his coronaries, and probably soon after radiation, either do a stress test or also some form of coronary evaluation, because I think we really need to look at them earlier. And I think we're going to prevent a lot of these terrible morbidities, because then it complicates the patient's cancer treatment, cancer options. If they have had the coronary event, then kind of their participation in clinical trials, other options for therapies become so much more complicated that we can really help them. So I'm a big believer we should start early, have a good baseline, and really quick follow-up as well.
I totally agree. And to answer your question about, how are you to know? And I think that's on us. And one, I think I encourage a communication where I think that this is something we probably itch to relay, but don't know that someone cares or wants to understand too. Where one, in the future, I hope that we do a better job of having things be easily interpretable. And when we summarize our treatment, our quick summaries should include things that can relay risk, like this was for heart and LAD dose, but in the meantime, until we do better at that on us, if you have someone and you're trying to assess all of their risk factors, exposure to the heart is a risk factor. And the simplest way, I think, to assess that is appropriately still, what was, asking the radiation oncologist, what was their mean heart dose? Or even, did they measure that? What did their LAD get a lot of dose? People do this in different ways. It's not standard enough to say what was their LAD B50 gray, although it should be, I think it should be. But you can actually ask them to measure that. It's not standard to always contour out the LAD. Not everyone measures it, but the field is really moving there. So you can ask, and I've actually standardized it in our department. Every breast, like everyone gets an LAD contoured now. But that doesn't happen everywhere. But you can ask, but you can always ask, what was the mean heart dose? And that's an easy one to conceptualize. Is it perfect? No. But does it give useful information? Absolutely. And it is pretty good enough of the time to know if it was under 10 gray for a lung cancer patient. Not that that's not nothing, but that's very different than if it was over 10 or around 20. And we think, we're moving towards a ideal for lung cancer treatment planning being under 10, but right now the limit and what we try to meet is under 20. So if you have someone from either esophageal cancer or lung cancer, or someone getting, or even mediastinal lymphomas and things like that, and you ask the radiation oncologist, what was their mean heart dose? That is something they should have readily available all the time, where you can just put it in a bucket. If it's like double digits, that's high risk. It's just a high risk factor. You don't have to think of that. Some of the ESMO data and other, like, is it over 35 and we're treated 20 with doxorubicin? Like, this is not the way things are practically happening in the modern treatment planning area. No one's getting a mean heart dose of 35 gray anymore. The people are getting 20. They're getting 20 to 25 in esophageal sometimes, and they're still getting routinely 10 to 20 gray in lung cancer plans all the time, unless it's like super far away in the right and there's no mediastinal nodes or something. But getting 12 to 18 gray to 20 gray in the heart all the time for lung cancer and esophageal cancer and big mediastinal lymphomas is a norm. And if you just know that, if someone told you that when they sent you a patient, that I think is the trigger to be like, that's a high. They are now, I think, someone who needs increased level of surveillance. What that means is still pretty nebulous, but it should factor in, I think, I assume that, to me, that means, like, I hope that relays to you as that's a high risk factor.
Yeah, and just to piggyback on that, I'm so glad that the recent European cardio-oncology guidelines really kind of, again, moved away from this 30 gray threshold, and now they're identifying patients 15 gray or greater as high risk, but even 5 to 15 gray with cardiovascular risk factors.
Yeah, definitely
followed. But when I was preparing for this talk, kind of all of the review papers and documents, still, high risk patients, 30 gray, and just again, Dr. Atkins opened my eyes about, oh my gosh, this is absolutely not true.
And what's confusing is often what they mean, like the ASCO guidelines, and what they mean is a prescription dose of 30 gray with the heart in the field. It's a very nebulous thing. That's very different than saying a mean heart dose of 30 gray. That just means that your prescription was a significant amount, like the prescription dose might be 60 gray for lung cancer or 40 to 50 gray for breast cancer, depending on how it's fractionated. The prescription was 30 and the heart dose in the field is how ASCO defines it, which is, how are you to know that? That's not something anyone else can, that's not something that can be figured out very easily unless you think about that, unless you're thinking about that. And so I think that that's on our guide, as we make these guidelines and try to be clear, we have to make this something that is easily interpretable. And I think that's one of the most challenges with radiation in this multidisciplinary field is sometimes the information isn't as easily interpretable, and that's on us to make it so, because it's like, what do people do with this, and what is this radiation, and where is it going, and what do we do?
That's great. I think let's, for the sake of time, to make sure we get through the rest of the cases, let's get to the case number 2 then.
Great. So on the case number 2, we'll focus on thoracic radiation and some of the arrhythmic effects associated in the recent data. Again, Dr. Atkins will present. So this is the case of a 73-year-old female with oxygen-dependent COPD. She was found to have right hilar mass and was ultimately diagnosed with stage 3A non-small lung cancer with really no PD-L1 expression. She was not a surgical therapy candidate, and she was started on definitive chemoradiation therapy with concurrent carboplatin and paclitaxel chemotherapy. So while at the infusion center receiving her chemotherapy, she developed symptoms of acutely worsening shortness of breath and palpitations. She was found to be tachycardic to the 160s, 180s. EKG was obtained demonstrating she was in atrial fibrillation, and she was referred to the emergency room for further management. Echo demonstrated EF of 56% with diastolic dysfunction, moderate MR, but no pulmonary hypertension. So Dr. Atkins also has some interesting research to present about the association of radiation therapy with arrhythmias.
And this is only just a couple of slides just to illustrate this is a lot newer in the field. I think initially we focused on the high morbidity ischemic events, understandably, but then the most common events after radiation for locally advanced lung cancer are arrhythmias. So there's about a 12% cumulative incidence at 2 years for grade 3 or greater arrhythmias, just all comers, at a median onset sooner than we usually appreciate at about a year and a half. And so we did a similar type of analysis. We don't need to go through, but basically look at different structures and find variables that try to predict for the specific event. So we grouped atrial fibrillation and flutter. We grouped other supraventricular tachyarrhythmias, ventricular arrhythmias, or bradyarrhythmias. And the most common, as expected, are atrial fibrillation with a sum of atrial flutter. And we found that left atrial doses associated most with that. And I'll focus on that because the atrial fibrillation associates with mortality. The other events aren't as associated with mortality events in these patients, not that they're not significant. But next slide. And so what we basically found was that the incidence, when we stratify by this dosimetric cut point in the left atria, is basically that we can predict for AFib better. When we look at dose to the left atrium, and this also associates with mortality. Next slide. But this is where I just pause usually, and this is when especially when I give this information to oncologists, is that there was a similar study that when we presented this data that came out in a similar recently in JAMA Oncology that identified the SA node and the left atria and the right atria associated with AFib and mortality. Very similar to our story looking at the left atria. But what I think we all did, us and the other group, is we missed it. We missed the story a little bit because as we went into this, as we started our project, we weren't thinking about, well, what's AFib going to be, and do we need a contour like the proximal pulmonary vein or the myocardial sleeves of the pulmonary veins? We didn't even know what arrhythmias would come out. And so everyone takes this approach. And when we contour the atria, it's like the blood pool. It's like the whole atria. And so we didn't come into this as elegant as when we think back on it now. And something that you all know very well is that, the ectopic foci mostly originate from the pulmonary veins and the myocardial sleeves there. So it makes sense to you and to think about it like that. But so really, when I think about this data, I think both our group and the other group is not quite there, meaning atria is better than other areas. But I think the blood pool of the atrium is still a little crude. And actually right now we're working to map it, basically to the pulmonary veins and define contouring the origin of the pulmonary veins as that probably will get us the right signal to say that this is where this is going to be most associated. So we can see the data panning out for the atrial doses and arrhythmia, but it just also goes to show that a lot of things happen to the heart, and we have to look at it with the right connection from the exposure to the area. There has to be a pathophysiological mechanism. We have to measure that appropriate endpoint, and then we have to put this together in mitigation strategy. So next slide. So really, I think that's just what we can skip. That's what I said on that slide. And that's what we're trying to do in the field now is basically, let's do better than the whole heart. But that means different events. And so there's going to be trade-offs. So you can't always spare the left atrium for a tumor and mediastinal nodes sitting right there. But what you can do is counsel the risk and have someone have their risk optimized by a cardiologist and cue people into the right surveillance and risk mitigation approaches, even when we can't always control the risk. But there are times actually we can do better on our planning approaches.
Great. We can also pause and see if there's any questions related to that, or we have another short case that's highlighting particularly the targeted therapies as well.
Let's go ahead and do the last case, just so we make sure we capture it within the time, and then we'll finish with the question and answers after.
Right, perfect. So another short case, this is a 60-year-old female with stage 3A lung adenocarcinoma. She underwent right lower lobe lobectomy and middle lobe wedge resection. She was treated with adjuvant cisplatin and a lymphed radiation therapy. She has also a cardiovascular risk factor, long history of controlled hypertension with medications, and she had the recent history of PE and DVT. She had exon 19 activating mutation in the epidermal growth factor receptor. And so she was started on osimertinib treatment with 80 milligrams per day. So about 2 weeks later, she was noted to have 10 pounds weight gain for oncology appointment. After additional 2 weeks, she was noticed to be severely short of breath or topnic with paroxysmal nocturnal dyspnea. And on echocardiogram, she was found to have an ejection fraction decreased to 45% with global hypokinesis, no valvular abnormalities, normal PA pressures. So this is one of probably I wanted to highlight this one because it's one of the most commonly encountered toxicities that I see in my clinical practice as well with EGFR targeted therapies, especially Tagrisso is one of the leading ones that is pretty extensively used. And probably most of you are familiar with this JACC Cardio-Oncology article that is highlighting outcomes with these therapies in terms of cardiotoxicity. It was done based on the FAERS database, a pharmacovigilance. It's a pharmacovigilance database. And it basically highlights that indeed the rate of EF decline, which is defined as at least 10% decrease from baseline to a new baseline of less than 50%, was about 2 to 5%. And additionally, it's associated with QTc prolongation, again, atrial arrhythmias. And so another therapy that is on the horizon of the lung cancer patients that has significant cardiovascular toxicity, probably similar to many of the HER2 therapies, and yet we don't have these guidelines in how to monitor these patients and how frequently to monitor their ejection fraction. Many of those EF declines are reversible if you catch them pretty early. And this is a real-world experience with osimertinib from a Japanese study. Again, similar rate of cardiac adverse events, about 5%, including MI, heart failure, and valvular disease. They weren't as granular in kind of looking at diastolic function or more granularly at the arrhythmias, but still very similar event rates. So how should we be monitoring these patients? I think that they're definitely at risk for QTc prolongation. So we should be on the watch out for any anti-nausea medications, concomitant antibiotics and other QTc prolonging medications. And I usually try to get basically EKGs on them initially pretty frequently, and then with any other QTc prolonging medications or dosage changes. But I think it's important to look at the EF and really follow them with serial echocardiograms, probably similarly to our breast cancer patients on HER2 therapies. So it's affecting kind of a similar pathway, survival pathway in the heart, and we should be monitoring them more frequently. But again, the focus is so away from these lung cancer patients that we should really kind of refocus the discussion that it's important to monitor these patients for these therapies. I'm going to briefly touch on the ALK inhibitors. These are another class of medications that are used in these patients with incredible survival benefit. And the big ones to be aware of, the crizotinib with the QTc prolongation and the alectinib, that they see a lot of bradycardias. Usually they don't progress to kind of more advanced heart blocks and are pretty benign and reversible, but scares a lot the oncologists and kind of other care providers for these patients. So really kind of to wrap up the talk today, I learned a lot from Dr. Atkins' research and kind of changed my practice as a cardiologist in that we really got to be aggressive in screening and protecting the lung cancer patients. I usually start statins at them at much lower threshold, especially if they're going to get left-sided chest radiation. I follow them very, very closely and really have seen pretty significant cardiovascular events happening very quickly to them, which has really scared me and kind of is consistent with what we've seen from her research. And obviously, we've got to work together with our radiation oncologists so that they're aware of these cardiovascular toxicities and refer to us, the cardio-oncologists, early. We can together strategize to minimize heart dose, protect the cardiovascular system of these patients with various therapies, and hopefully we'll have some clinical trials and research studies to see what is the optimum way to protect them and screen these patients. So thank you again for this attention, and kind of we'll take any last minute questions in the last 5 minutes.
I don't see any questions right now from the audience, but I did have a couple things to bring up. Dr. Atkins, I was actually, thank you again for both of your talks. They're incredible, and the data and work that you're doing is really groundbreaking, I would say, from a radiation oncology perspective. I think this idea of kind of an LAD dose makes a lot of sense. It's one of those things, I think, in medicine that in retrospect make a lot of sense, but we didn't think about it at first. I was interested to hear about, with respect to your experience and the data that you guys have been obtaining, is with respect to the use of the platinum doublets as well as the immunotherapies in particular. Have you kind of segregated out that data with respect to the radiation, LAD dose, and are you seeing in particular higher incidences of CAD and or harder outcomes with respect to MIs with folks that have potentially even lower LAD doses that are on these other concurrent therapies?
That's a really good question. I think the short answer is not yet. I think that our data predates the immunotherapy blossoming. So our data was just when people were starting to use immunotherapy with that time for the outcomes analysis. So that's underrepresented. And what likely is going to happen is that there is overlapping toxicities, and there probably is going to be a role for understanding the timing and overlap. And we know we know of the synergistic toxicities with, for instance, pneumonitis, and along with immunotherapy and radiation therapy and certain targeted therapies. I imagine that inflammatory cascade is going to have a similar potentially bad synergistic role in the heart as well. And I think that's like the next wave of this. And the waters are muddy, right? These patients are getting a multitude of treatments, and teasing them apart can be really challenging, especially in lung cancer. They're getting multimodality cardiac toxicity treatments. But I think that's the next wave that we need to get data on. And it doesn't exist yet, but I imagine that exactly as you described it, that's going to get identified, is there is going to be a timing, and there is going to be a timing in a subset of patients who have an even higher risk exposure. And timing of immunotherapy and radiation matters. Immunotherapy before radiation can sometimes prime response to toxicity, particularly in the lung. And so we're going to have to be mindful of this, because there's probably a sequencing that matters as well.
That's great. And then the other question I had with respect to more of the arrhythmias, we kind of, or you guys had touched upon the I would say kind of more tachyarrhythmias with respect to, atrial fibrillation, et cetera. I'm sure looking at the dose to the, atrioventricular node has been looked at for, heart block and such. But I was also wondering about the kind of increasing recognition to autonomic dysfunction. We get a lot of this clinically, and I was wondering, as far as if any of your research or anybody in the country's research is looking at the autonomic dysfunction and dose and kind of what's being targeted.
So that's a really good question. So actually, Anju Noria at the Brigham, who brought this up when we were doing this data together, and that's really a focus of her interest as well. And it was hard to tease apart. There's a handful of patients on our series with autonomic dysfunction, but not in a way where we could capture, and it's so hard to pull that out retrospectively, as I've learned about how to really properly classify autonomic dysfunction. But I think so I think that's still an open, that still needs better analysis. There's some whole heart data that is going to emerging in this, and that we know with head and neck irradiation and carotid exposure, and we really don't have a good handle on predicting and mitigating. And I think that's one where It's often overlooked. The data is better in the long-term, like Hodgkin and lymphoma survivor data, but it's still, that's really undercaptured and underappreciated and needs a lot more work to bring it up to a level where we can risk stratify and identify mitigation approaches.
Yeah, and just to add on to that, I don't think that we're kind of systematically assessing for it, right? It just
No, it doesn't actually have a category. It doesn't have a CTCA category and NCI definitions. And there's actually, and it's actually very hard to pull it out in the way that from retrospective data. And so actually we need to be more thoughtful, and that probably should be a category so that on prospective trials for cardiac toxicity for thoracic and head and neck, there should be a way to have this be captured as an event to help answer this question in the future. So even the CTCE for NCI grading of events is in version 5. And when we started this, it was in version 4, and there wasn't a QTC prolongation. There is now, but there wasn't there. So it's like you're going through 30 categories of things, and some of them aren't even capturing all of the things that are relevant. So QTC is now in, prolongation is now in there, but then as people are doing targeted therapies, but before that iteration, they're not even being captured in a prospective way, in a methodical way that's graded.
Yeah, and probably we cardiologists can also a little bit highlight the various things that we screen for when we see these patients. I mean, the resting echocardiogram, structural heart disease, and valvular problems. But on stress echocardiogram, we're looking for signs of autonomic dysfunction. We're looking at their blood pressure response and heart rate recovery response. And we've got to be capturing these data points a little bit better so we can really look at those as well.
But I also reciprocally think that as like oncology clinical trials are designed and these types of criteria are assessed, we need your minds to say, are we missing the capturing of relevant things, and how are we assessing this? And because I think that we've had these separate communication lines, not speaking the right overlapping language, and it's led to a lot of initial literature that doesn't quite meet the information that the other group needs to really have a productive dialogue on what to do with these patients and toxicities.
That's a really good point. I think that's kind of as this discipline continues to evolve within cardio-oncology, that's the kind of exciting part of meeting new friends and colleagues and kind of exploring these avenues that really haven't been kind of addressed before, or maybe under addressed just because someone's missing the clinical aspect that the other field is looking at on a clinical day-to-day basis. So I really am excited for the work that you all are doing and work across the country in all of this radiation oncology, in addition to targeted therapeutics, immunotherapy. I mean, people are really doing groundbreaking work, and I think that's a testament to just really working together and collaborating. So well, it is 3 past the hour. I want to, Dr. Bassi and I are very just thrilled with this talk. And again, Dr. Atkins, Dr. Nikolova, thank you so much for all the work you're doing, the time you spent to prepare and to be here with us. For everyone that was available to be live in the audience, thank you for participating. Again, Leanna will be posting this after it's edited to the California ACC website. So please review it at your leisure, and stay tuned for additional webinars in the cardio-oncology series here. And everyone have a great night. Thank you so much.
Thank you so much for
Thank you for a great talk. That was great.